Hello everybody and welcome to our module on cardiac embryology. About 3 weeks after the egg is fertilized, the primitive heart develops in the embryo, and one thing you should be aware of is that the primitive heart develops as a straight tube which will eventually fold and become the structure that you know in the adult. And all the different bulges on the tube have names, and you need to know what the names are, so let's go over them now. So at the top of the tube is a structure called the truncus arteriosus. Below that is the bulbus cordus. We then have a bulge called the primitive ventricle, followed by another section down at the bottom here called the primitive atrium, and then finally at the very bottom we have a structure called the sinus venosus, which has two horns, as you can see in this picture on the screen. The truncus arteriosus has the word artery in its name, and that can help remind you that in the adult heart, the truncus arteriosus develops into the aorta, which supplies all our arteries, and also into the pulmonary artery, which has the word artery in its name. The bulbus cordus develops into the smooth portions of the left and right ventricle. I'll show you a picture of those in a minute. The primitive ventricle develops into the trabeculated portions of the left and right ventricle. The primitive atrium develops into the trabeculated portions of our atria. And finally, the sinus venosus develops into the right atrium and coronary sinus. And here I've zoomed in on the sinus venosus so that I can show you that the right horn develops into the smooth portion of the right atrium. This is called the sinus venarum. And the left horn develops into the coronary sinus. And an easy way to remember this is that the coronary sinus drains blood from the left ventricle, therefore it comes from the left horn. The smooth right atrium comes from the right horn. And then finally, I'll mention structures in the embryo called the cardinal veins. These are the structures that form the SVC and the IVC. The vena cava do not come from the heart tube. The cardinal veins will eventually connect to the right atrium and form the SVC and IVC. The superior vena cava comes from the right common cardinal vein and the right anterior cardinal vein, and the inferior vena cava comes from posterior cardinal veins. Here's a picture of the adult heart, and I just want to point out to you that in the adult heart you have these bumpy sections. Those are called the trabeculated portions of the chambers. You also have these smooth sections up here, and the reason some portions are trabeculated and some are smooth is because they derive from different embryologic structures. And the smooth portions are generally found where the heart connects to other vessels. So for example, you can see smooth sections here right below the aortic valve. You can also find smooth portions below the pulmonic valve and near the connections to the vena cava and pulmonary veins in the atria. So I mentioned this before, but the primitive heart tube will fold and become the adult heart that we know. This process is shown on the screen here. And if you want to understand how this happens in 3 dimensions, go to YouTube and Google heart embryology, and you will find an old video that shows a beautiful cartoon of how this happens in 3 dimensions. Now, at the same time that the heart is folding, inside of the heart, walls are being built. Walls between the left and right ventricles, walls between the left and right atria, and even a wall that separates the pulmonary artery from the aorta. So in the next few slides, we're going to talk about how all of those walls form while the heart is folding, like is shown on the screen here. Let me briefly mention a process that occurs in the embryo called cardiac looping. The heart tube loops at about 4 weeks of gestation, and this establishes the normal left-right orientation of the heart in the chest. You may know that your heart is normally found on the left side of your chest, and that's because of the process called cardiac looping. This process requires cilia and dynin, and I discuss both cilia and dynin in videos in the cell biology section, but cilia are motile structures and dynin is an important motile protein, and they need to function normally for the heart to orient correctly in the chest. If cilia and dynin are abnormal, this can lead to dextrocardia. This is when the heart is found on the right side of the body. This is an x-ray of a patient with dextrocardia. Note that the heart is located on the right side of the chest, not the left side where it should be. And dextrocardia is seen in Cartaginer syndrome, which is part of the disorder called primary ciliary dyskinesia, and I discuss both of these things in videos in the cell biology section. Now let's talk about the formation of the ventricular septum. This is the wall that will eventually separate the left ventricle from the right ventricle. So initially the ventricle is a single chamber that will be divided, and it's rare, but sometimes children are born with a single ventricle. This is a severe form of congenital heart disease. There's an outgrowth of the ventricular chamber which will eventually form the pulmonary artery and the aorta, and it has a septum dividing it, and that septum will divide this outflow into the pulmonary artery and aorta. So the first step in this process is that a structure called the muscular ventricular septum begins to form. That's shown in blue here. This forms at the bottom of the ventricle and grows upward towards the outflow section of the ventricle. Next, what happens is that the membranous septum forms. The way this happens is the aorticopulmonary septum begins to twist. You may know that the pulmonary artery and aorta twist around each other. So this happens in the embryo. The aorticopulmonary septum twists, and then it fuses with the muscular septum and forms this green portion of the interventricular septum called the membranous septum. After this step, structures called the endocardial cushions appear, and they will separate the right and left atria and the right and left ventricle. And the final result is that you have a single septum separating the left ventricle from the right ventricle. And if you know the names of the structures in the embryo that form the ventricular septum, then it's easy to understand ventricular septal pathology. There are a number of forms of ventricular septal defects, and some of them are called membranous. This is the most common type. Others are called muscular. And the reason they are named this way is because this represents the structures from which they derive in the embryo. I mentioned the endocardial cushions before. Those are these two yellow squares I've shown on my little drawing here. And these are very important structures in the embryo. They contribute to several cardiac structures in the adult. They contribute to development of the atrial septum, the ventricular septum. They also contribute to development of the AV valves, which are the mitral and tricuspid valves, and also the so-called semilunar valves, which are the aortic and pulmonic valves. And sometimes children are born with a form of congenital heart disease called endocardial cushion defects. These are also sometimes called atrioventricular canal defects or atrioventricular septal defects. And these defects involve several different parts of the heart in the adult. They can involve the atrial septum and involve an atrial septal defect. They can also include a VSD, and they can also include valvular malformations. And this type of embryologic heart defect is common in children in Down syndrome, which I talk about in the video on Down syndrome in the genetics section. I also mentioned before an important structure called the aorticopulmonary septum. It's also sometimes called the spiral septum. If you look at this picture at the bottom of the screen, in the embryo, the ventricle has a single outflow tract, but the aorticopulmonary septum will divide it into the aorta and the pulmonary artery. And it's very high yield for you to know that proper formation of this septum requires neural crest cells. This may seem strange since neural crest cells play such a big role in development of the nervous system, but they also play a role in developing this septum that divides the pulmonary artery from the aorta. These cells migrate to areas in the primitive heart tube called the truncal and bulbar ridges. If you look over at the drawing on the right side of the screen here, there are ridges between the truncus arteriosus and the bulbus cordis. The neural crest cells migrate there, and then they form this septum which separates the aorta and pulmonary arteries, and as I described earlier, it fuses with the intraventricular septum to help form the membranous ventricular septum. If this septum does not form normally, that can lead to a number of congenital heart defects. Transposition of the great vessels can be caused if this septum fails to spiral normally. Tetralogy of Fallot can be caused if this septum is formed in a skewed manner. And a persistent truncus arteriosus can develop if there is partial or incomplete septum development. And I talk about all of these disorders in another video, but I just want to mention here that they all derive from abnormal formation of the aorticopulmonary septum. Now let's talk about how the atrial septum forms. This is the wall that separates the right atrium from the left atrium. This process begins with the endocardial cushions at the base of the atrial chambers and the septum primum, which is a structure that forms at the top of the atrial chambers. The septum primum will begin to grow downward toward the endocardial cushions. The tricky part about this process is that as it is growing downward, a hole opens up in the back of the septum. That's this hole right here. This is called the foramen secundum. So once the foramen secundum opens up, you now have two holes between the atrial chambers. You have the foramen secundum up at the top, and you have the foramen primum down at the bottom. The septum primum will eventually fuse with the endocardial cushion, as I've shown here in my drawing. This will eliminate the foramen primum. It will leave only the foramen secundum as a communication between the two atrial chambers. A new structure will then form called the septum secundum. This will grow downward and cover the foramen secundum. At this point, you have a situation where the septum primum, shown in blue here, functions like a valve. Pressures in the fetus are very high in the right atrium, so it will push this septum primum to the right and allow blood to flow between the two chambers, as I've shown with my black arrow here. And this opening between the two chambers formed by the septum primum functioning as a valve is called the foramen ovale. At the time of birth, the foramen ovale should close. If you look at the bottom right side of the screen here, at the time of birth, pressures in the left atrium become very high. This will push the septum primum against the septum secundum, and they should seal together and eliminate the foramen ovale. However, in about 25% of adults, this doesn't occur normally, and they are left with what's known as a PFO, or patent foramen ovale. This is caused by failure of the foramen ovale to close after birth. It's caused by the septum primum and secundum failing to fuse together. And in my practice, when I perform transesophageal echocardiograms, I frequently identify a PFO. They're found in 1 out of every 4 patients. This is a picture of a PFO by transesophageal echocardiogram shown on the screen. This is the right atrium here. This is the left atrium here. You can see this flap, which has an opening between it that allows blood to travel from the left atrium to the right atrium, or from the right atrium to the left atrium, depending on the pressures. I'll finish this video by talking about the fetal circulation and how that circulation changes at the time of birth. The key to understanding the fetal circulation is to remember that physiologically there is very high resistance to flow in the lungs. The lungs are filled with amniotic fluid, and it's very difficult for blood to flow through them in the womb. This is okay for the baby, however, because oxygen is coming from the mother by way of the placenta. The umbilical veins contain oxygenated blood. Now, interestingly, the partial pressure of oxygen in the blood in the umbilical veins is relatively low, about 30 millimeters of mercury. However, this results in a saturation of hemoglobin of about 80%, and that's because fetal hemoglobin has a strong affinity for oxygen. That oxygenated blood from the placenta and the umbilical veins travels straight to the right atrium. It bypasses the liver via a structure called the ductus venosus. This is because the liver is relatively unimportant in the fetus, since the mother is performing many of the metabolic roles of the liver. Once the blood gets to the heart and the right atrium, it can bypass the lungs via the foramen ovale, which we previously discussed. This is shown in this slide at the top right of the screen. The foramen ovale is here, and it allows oxygenated blood to bypass the lungs. The blood doesn't want to go to the lungs because resistance to flow is high, so it will bypass the lungs, go through the foramen ovale, and travel to the left atrium. Now, some blood, especially blood from the head of the fetus, will still get to the right ventricle. In other words, it won't go through the foramen ovale. If you look at this picture on the right side of the screen here, blood coming from the head may go straight down and through the tricuspid valve and enter the right ventricle. But there's a second bypass structure for the lungs called the ductus arteriosus. This is shown in this picture here. It connects the pulmonary artery to the aorta. So once again, this allows blood to bypass the lungs and travel to the left side of the heart. If you remember that resistance to flow in the lungs is very high in the womb, then it's easy to remember that the major change at birth is that pulmonary resistance falls. The baby takes a breath of air. This starts to remove fluid from the lungs, and the lungs fill with air, and the resistance gets much lower. This allows a rush of blood to travel from the right ventricle and pulmonary artery through the lungs. This leads to more blood in the left atrium, and it raises the pressure in the left atrium so that it becomes higher than the right atrial pressure. This is going to close the foramen ovale in most cases so that it becomes the fossa ovalis. Like I showed you before, when pressure in the left atrium becomes high, it pushes that septum primum against the septum secundum, and the two structures fuse together. The ductus arteriosus, the other bypass of the lungs, will also close. In utero, you have relatively low oxygen tension in the ductus arteriosus, and you have lots of prostaglandins around coming from the placenta. This maintains the patency of the ductus arteriosus. At birth, the oxygen content of the blood in the ductus arteriosus rises because the lungs start to work, and the level of prostaglandins fall because you lose the placenta, and these are the two major triggers for closure of the ductus arteriosus. So at the bottom of the screen, I've highlighted the key physiologic changes between in utero and at birth, and these are very high yield for you to know for step 1 of your boards. So the resistance to flow through the lungs, the pulmonary vascular resistance, is very high in utero but falls at the time of birth. The pressure in the right atrium is very high in utero. This is what drives blood across the foramen ovale, and at birth the pressure in the right atrium falls because blood begins flowing into the right ventricle and through the lungs. In the left atrium, in utero, the pressure is relatively low, but at birth there is a rush of blood coming through the lungs. This raises the pressure in the left atrium and seals the foramen ovale closed. And then the final topic that I'll mention in this video is that the placenta has a low resistance to flow, and in utero this helps to keep the left atrial pressure low. Remember that the left atrium pumps blood into the left ventricle, and in utero, the left ventricle has a very easy time moving blood into the aorta. That's because the aorta is connected to the placenta, which is a very low resistance structure. So it's easy for blood to move from the left ventricle to the aorta, and therefore it's easy for blood to move from the left atrium to the left ventricle. And this helps to keep the left atrial pressure low in the baby in the womb. Now at birth, when the placenta is lost, there's a rise in peripheral resistance. This is one of the physiologic changes that occurs at birth. This leads to a rise in systemic blood pressure. Basically, the afterload on the left ventricle goes up and the blood pressure rises. This leads to a rise in left ventricular pressure, and this in turn contributes to the rise in left atrial pressure that occurs at birth and helps to close the foramen ovale. And that concludes our video on cardiac embryology.